Vou falar sobre os obstáculos para a eliminação da infecção por HIV. So we have an incredible armamentarium of antivirals targeted to different stages of the viral life cycle. And these cocktails have dramatically altered the prognosis for individuals living with HIV. And that message I'm going to keep bringing up as I discuss what arguably is one of the scientific challenges for the field, identification of a cure for HIV. But not just a cure that could have a global impact. So when I discuss some of those strategies that are currently being explored to eliminate HIV, we always have to consider how those strategies are going to play into the current situation, which is an incredibly effective antiretroviral program that has had a global impact and that is very safe for individuals on long-term regimens. So we have treatments that have dramatically altered the outlook for individuals living with HIV. And although these cocktails are, of course, very effective, they don't cure HIV infection. In addition, we have drug resistance, we have treatment drop-off, pill fatigue, and because of those, there is a fairly high drop-off in terms of individuals who stay on the antiretroviral cocktails. But one of the driving forces for a cure is not just to not have to take these antiretroviral cocktails, but the stigmatization of being HIV infected. And in some surveys, at least in the United States, stigma is the major driving motivation for the development of an effective cure for HIV infection. We have Rock Hudson on the left, Magic Johnson in the middle, and Charlie Sheen on the right. And a number of famous individuals who are living with HIV have often stated publicly that the stigma of HIV infection is a hard thing to live with, in addition to being on 1 or 2 pills a day for the rest of their lives. And that stigmatization can take many forms. For example, individuals are worried about losing their job. They're worried about what their family members are going to think and whether they're going to be exorcised from the family unit. They're worried about their insurance and whether their insurance would be inactivated because of their HIV status. So perspective, the personal perspective and the stigmatization is a powerful driving force in terms of pursuing a cure for HIV. Then the practicalities of lifetime antiretroviral infection. So despite the targets set by the World Health Organization, 90% of individuals should know their HIV infection status. 90% of those should be on antiretroviral therapy, and 90% of those should have an undetectable viral load. But the reality is that many countries are falling far short of those targets, to the extent that less than 50% of the global population on antiretroviral therapy has an undetectable viral load. So the limitation with the current therapeutic regimens is that need to adhere to those daily interventions for life. However, that situation is likely to change dramatically with the advent of long-acting formulations that should improve adherence. So the question is, with more effective antiretroviral regimens and long-acting regimens, will there still be a robust rationale for a practical and scalable cure for HIV infection? So if we are to embark on a cure, what do we know about the obstacles to elimination of the virus? And what's the current thinking regarding how the virus persists in the face of antiretroviral therapy? Most of the attention in this area has focused on the memory CD4 T cell. The memory CD4 T cell is what provides an individual with lifelong immunologic memory the ability to respond to pathogens in adulthood that were first encountered in childhood. So HIV has a predilection for infection of these cells. And because of the lifespan of the memory CD4 T cell, the integrated provirus takes on that same characteristic, that same longevity characteristic exhibited by the infected host cell. So this is considered the single biggest obstacle to HIV cure. These latently infected cells are very rare. The estimates on the number of infected cells in an individual, latently infected cells on an individual on suppressive antiretroviral therapy is continually being revised. But the most challenging aspect of the latent reservoir is that there's really no, to date, identifiable markers that could distinguish a cell from harboring a latent HIV genome. There was some excitement around CD32 as a possible marker on a latently infected cell, but that did not withstand scrutiny. So scientists are trying to find out if there's something different about a latently infected cell that could distinguish it from an uninfected cell, so that that would aid in design of strategies that could zero in on that cell and eliminate. And so the cure strategies on elimination of this reservoir are focused on elimination of the infected cell through shock and kill, or block and lock that you'll hear in the next lecture, as well as genetic approaches using CCR5 or proviral excision, for example, using CRISPR-Cas9 strategies. The problem is that without an identifiable marker, the problem faced by scientists is that you're trying to remove those rare latently infected cells that can be distinguished from uninfected cells, which forces the possibility that you would have to remove many cells, both infected and uninfected, to get at those rare latently infected cells. So this is really a challenge facing the HIV research community at this time. Now, some of those latently infected cells undergo homeostatic proliferation, and this has really captured a lot of attention in the last couple of years. First identified by Jim Mullins and colleagues, and by John Coffin, John Mellors and colleagues. And basically what happens is that when an latently infected memory CD4 T cell goes through mitosis, the cells, the two daughter cells that are formed, each carry an identical provirus. And that process can occur over and over again to the extent that the majority of cells harboring HIV genomes, at least in the peripheral blood, are the result of duplication at homeostasis. In some individuals, 30% of the proviruses in peripheral blood can be derived from a single ancestor. They have identical integration sites and identical sequences. Now, originally it was thought that these expanded proviruses really were expanded defective proviruses, that the process of mitosis would not allow a competent provirus to go through duplication without killing the infected cell. And that turned out not to be the case. And at CROI in 2019, John Mellors and colleagues presented evidence that this population of expanded proviruses may be the source of low-level viremia that persists in some individuals, a significant percentage of individuals, on long-term antiretroviral therapy. So this reservoir does have the capacity to maintain HIV persistence and to maintain HIV in a biologically competent form that may be able to fuel recrudescence if treatment is interrupted. And then the final mechanism of persistence, which is the most controversial, is the possibility that the antiretrovirals have not, in fact, completely shut down all HIV infection in the individual, but there may be ongoing rounds of infection, or at least new infected cells being generated, even in the face of overwhelming antiretroviral therapy. Now, there's several hypotheses as to how this could occur. There's evidence that B-cell follicles may provide a sanctuary site. They are inaccessible to cytotoxic T cells that are meant to control HIV infection. But the lack of sequence evolution in individuals on antiretroviral therapy argues against this being a common practice in HIV infection and arguing against it being an important mechanism for maintenance of the viral reservoirs. And there's also evidence that in dysbiosis, where the microbiome is comprised of dysbiotic bacteria, that some of those lactobacilli can actually hydrolyze the drugs and reduce some of them to below effective levels. And that's work from Nikki Clark and colleagues published last year. But at least if this is occurring, one would predict that cells that are manufacturing virus and passing the virus onto other cells should be discernible by the presence of specific markers of infection in the cell surface that could aid in their clearance. Despite all this effort, though, one important question regarding the actual identity of the reservoirs that maintain HIV persistence has really not been substantiated to any great extent by treatment interruption studies. So by this, what I mean is, if individuals are on treatment and suppressed and undergo what we call an analytic treatment interruption, and the virus rebounds, where is this virus coming from? So presumably, the composition of this rebounding viremia should reflect the origin of the origin of the virus, or the reservoirs that produced this recrudescing virus. So it remains to be determined whether or which of these reservoirs that we've spent a lot of time characterizing, at least from peripheral blood, is actually contributing to the greatest extent to this treatment rebound. How much of that treatment rebound originates from the latent reservoir, from the expanded reservoir of duplicated proviruses, or from the active reservoir? And some individuals have started to look at this. For example, at CROI in 2019, Michelle Nussensweig and colleagues looked at the relationship between the latent reservoir and this recrudescing virus in individuals who had failed treatment with broadly neutralizing antibodies. And surprisingly, what they found was a rather limited overlap between the latent pool, at least in the peripheral blood reservoir, and the recrudescing virus post-analytic treatment interruption. So this is obviously going to be something that many individuals are going to be looking at, because we want to be sure that the window that we're looking into to characterize this reservoir that persists in infected individuals is actually a faithful reflection of the reservoirs that actually exist and that actually perpetuate HIV in the face of potent antiretroviral suppression. So given these three mechanisms of viral persistence, what might be the strategies that we could use to promote elimination of these reservoirs? Either by ultimately getting to a sterilizing cure where all vestiges of the virus in the infected individual have been removed, or a functional cure where not all of the virus has been removed, but it's been suppressed to a level that allows the immune system to contain the virus in the absence of antiretroviral therapy. And I think it's safe to say that most of the strategies being explored are really focused on that second option, the functional cure. Because a sterilizing cure is still considered beyond the scope of feasibility at the current time. So some of the strategies I'm going to briefly overview include gene and cell-based therapies, shock and kill, block and lock, early antiretroviral therapy, and immunotherapy. So for gene and cell-based therapies, I think most of the attention worldwide has focused on the recent demonstration of a second cure. We're fortunate to have at the conference this year Timothy Ray Brown, who has really provided the rationale, the impetus for the field to pursue a cure for HIV infection. So Timothy now has a kindred spirit, commonly referred to as the London patient, which was presented at CROI this year. And there are some similarities and differences between the two individuals. First, we know what Timothy Brown looks like. As of yet, we don't know what the London patient looks like. Both received hematopoietic stem cell transplants. Timothy received 2 stem cell transplants with bone marrow from an individual who had a homozygous 32 base pair CCR5 deletion, whereas a London patient received a single transplant. Timothy Ray Brown was irradiated. The London patient was not. That's an important difference in terms of the aggressiveness of the procedure. Timothy Ray has been in remission now for over 10 years, whereas the London patient has been in remission for 3 years. And the presenter at CROI was careful to avoid the use of the word cure because, of course, there have been some heartbreaking examples of individuals who were in long-term remission who were thought to have been cured and who rebounded, for example, in the case of the Mississippi baby, almost 4 years after coming off antiretroviral therapy. So we have to be careful in terms of calling a cure. But I think 2 of the most interesting features of these individuals is the dramatic reduction in HIV-specific antibodies. In case of Timothy Ray Brown, HIV-specific antibodies are undetectable. One could even say seroreversion. And the London patient is showing a similar very low level of HIV-specific antibodies. So the question is, if we're going to rely on certain markers to determine whether we think someone has been cured and could be taken off antiretroviral therapy, perhaps the level of circulating antibody could be one of those markers that could prioritize individuals for undergoing treatment discontinuation. As of now, really the only way for us to gauge the progress of a cure trial is to take individuals off antiretroviral therapy and then look at how long it takes for the virus to rebound because, well, without much substantiating data, the field generally believes that the time to treatment rebound following treatment discontinuation reflects the size of the reservoir. The longer it takes to rebound, the smaller the reservoir size. But that really hasn't been substantiated to any great extent. Now, the question is, can hematopoietic stem cell transplant pave the way to a cure? Sure, there are lessons to be learned here. But, for example, in our clinic, we've had dozens of requests from individuals who are HIV infected and who want to undergo a bone marrow transplant because of, you know, the publicity surrounding the London patient. But we have to really look at the background of bone marrow transplant and the hazards associated with it. So both the London patient and as yet undisclosed Dusseldorf patient appear to be in long-term remission. They are both participants in a consortium called ICI STEM, funded by the American Foundation for AIDS Research. Upwards of 30 participants who have received hematopoietic stem cell transplant because of hematologic malignancies. It was at the caipirinhas last night, I think they're getting to me. So they are, of these 30 individuals, there's now about 1/3 of the individuals have died as a result of complications with the bone marrow transplant. However, this trial is really trying to identify markers or indicators that could help us better define what a cure might look like and to recreate that condition in a safer modality, for example, using genetic approaches to eliminate CCR5. But most importantly, the scientific community really has to convey this message to people living with HIV infection in a responsible manner so as not to create false hope for individuals living with HIV. Shock and kill is something that we cover every year at this conference. It's still arguably one of the most intensive areas of cure research. The rationale is simple, that the latently infected cell is triggered to exit latency, and the resumption in viral replication when latency is interrupted should theoretically lead to killing of the cell by viral cytopathic effects, because HIV is a cytopathic virus, and or elimination of the cell by host immune surveillance. And there are multiple latency reversing agents that have been explored, some in the clinic, but the effect has been modest at best and very inconsistent. The same latency reactivation agent studied in 2 different clinical protocols yielded very different results. And the reason for the differences in the results is still unclear. Nevertheless, there's still a lot of basic science, discovery science, aimed at identifying novel reactivators of HIV that could more profoundly rekindle viral replication, and even agents that could be used in combination to deliver a more effective shock so as to interrupt latency. Those were summarized in an article by Sharon Lewin and colleagues in 2018, and some of these latency reactivators target very different processes in the cell, including NF-kappa B, PI3 kinase, T-cell receptor activators, TLR agonists, and most of them focused on modifying chromatin so as to expose the provirus to transcription factors. As will be discussed in the next lecture by Susanna Valenti, an alternative strategy is not to awaken the virus from latency, but actually to keep it locked in a state of latency. It's a strategy commonly referred to as block and lock. Susanna here looking like a 15-year-old student. Actually, she still looks like a 15-year-old student. Where's she here? Yes, there she is. And so Dr. Valenti's group is focused on using agents such as cortistatin A to keep the virus locked in a deep state of latency so that the latently infected cell cannot undergo a period of reactivation and rekindle viral replication. And the strategy has been shown to keep the virus locked in a state that's difficult to reactivate, even with the most potent latency reactivators. But more from Susanna in the next lecture. And then some individuals have been exploring early antiretroviral therapy as a way to limit the size of the latent reservoir that's established following acute infection. And the rationale is that by starting treatment early, you could perhaps limit the establishment of latency to the same extent that would occur in individuals who do not start treatment early after infection, and perhaps preserve immune function so as to better control the virus through post-treatment control with a more functional immune system. So one recent case of an individual who was treated very early was actually an individual who was being assessed for pre-exposure prophylaxis. And when individuals are assessed for pre-exposure prophylaxis, they obviously have to have a rapid HIV test to make sure they're not already infected. Those who are infected at that visit can then be signed up for antiretroviral therapy. So this individual went on treatment literally within a week or so of the HIV infection. And then the virus in the individual dropped precipitously within the first month of infection, and the investigative team examined viral reservoirs in this individual, not just through ultrasensitive plasma viral RNA assays, but also through rectal biopsies, pinch biopsies, viral outgrowth assays, and using droplet digital PCR measures that get down to less than 1 copy. And for basically 10, 11 months, the virus was undetectable. So this appeared to be a case of either a long-term remission or cure. However, as was seen with one of the Boston patients who underwent a bone marrow transplant with wild-type, CCR5 wild-type bone marrow, this individual rebounded around 10 months after treatment was interrupted, pretty much identical to patient B of the 2 Boston patients originally described by Dan Koretskis and Tim Hinrich, who's shown here. And I think the message here is that you're catching someone early, you're reducing viral load, and perhaps in the absence of a robust immune response, even though you've been able to limit the size of the reservoir, there's really nothing to contain the small amounts of virus that could be there and could resume viral replication. So that poses a risk to the individual and their sexual partners. Similar message has emerged from Jintanat and Moronich's group, where they've been looked at the impact of very early antiretroviral therapy, and basically shown that even with antiretroviral therapy, once treatment is interrupted, there's pretty much a rapid recrudescence in plasma viremia. So the theme here is that while early antiretroviral therapy might reduce the size of the reservoirs, it really doesn't take much virus to resume explosive viral outgrowth once treatment is interrupted. So let's move on to the concept of immunotherapy. You know, immunotherapy has received encouragement from monkey studies. It seems that curing SIV or controlling SIV in monkeys, at least from the cadre of scientific publications, appears to be relatively easy and straightforward. So multiple examples in the literature of vaccine modalities, broadly neutralizing antibodies, early antiretroviral therapy seem to create a period of long-term remission and virologic control. However, there is the findings with humans have been less than stellar. Most of the attention, of course, is focused on the Visconti trial, individuals who went on treatment early, and after coming off treatment, many of those individuals controlled the virus. And in the therapeutic vaccination out of Tony Fauci's lab, it was also found that individuals initiating therapy early were able to better control the virus. So some, about 10 to 25% of individuals who start therapy early, but not too early, and remain on therapy for years will exhibit at least some partial control if treatment is interrupted. It may also occur in chronic infection, but it's far rarer observation in chronic infection. There's no biomarker to define to help predict who might be a virologic controller. And the mechanism is unknown, but at least if we combine studies of elite control, post-treatment control, and post-vaccine control, those studies do present some encouraging evidence that the immune system can effectively control the virus. But again, the mechanisms remain undefined, and dendritic cells, cytotoxic T cells, NK cells have all been implicated in virologic control in this group of individuals. And then using immunotherapy to enhance T-cell T-cell function, sorry. So some investigators have started to draw attention to the similarities between HIV persistence and cancer. So in HIV and cancer, we both see increased immune checkpoint markers on antigen-specific cells, epigenetically programmed and exhausted T cells. There's a reduced antigen burden with antiretroviral therapy, and chemotherapy, radiotherapy, and surgery are all used to achieve the same result. And then we have long-lived forms of HIV-infected cells or cancer stem cells with slow cycling and indefinite proliferative potential. And if we look at the nature of the reservoir, some studies point out that the reservoir appears to be enriched in individuals expressing markers of T-cell exhaustion, including PD-1, TIM3, and TIGIT. And CD8 T-cell dysfunction can also be reversed ex vivo in infected individuals on antiretroviral therapy with inhibitors of those exhaustion markers such as PD-1, CTLA4, and TIGIT. However, it's unclear whether the presence of the virus, the higher frequency of latently infected cells in exhausted CD4 cells is a consequence of the presence of latent virus or a reflection of the predilection of latency to occur in that type of exhausted CD4 T cell. So where are we in well, we're in 2019, of course. But in terms of what the thinking is between the rationale for cure in this when we have a very effective antiretroviral program to control HIV. What we can say is that reducing the reservoir size is possible with early antiretroviral therapy and transplantation. However, the effect is incomplete and not scalable. And I'll go into that shortly. Proof of concept exists for most steps in the shock and kill strategy, but the approach is not expected to be fully curative. So I guess one could say that the same approaches being used for combination antiretroviral therapy are likely to prove essential going forward with an HIV cure, in that one single strategy would not be effective, but combining different strategies is likely to be more successful to effectively reduce the reservoirs. Block and lock remains promising, but is yet to be tested in the clinic. And using immunotherapy, particularly in combination with other cure modalities, may reduce and control the reservoir. That might be the most promising approach to achieving a functional cure, but of course, as we discussed earlier, we're still going to, those individuals are going to still be faced with stigmatization. And then post-treatment control provides proof of concept that a durable and effective immune host response can be induced or improved therapeutically. And cancer immunotherapy provides further evidence that the immune system can be retrained to effectively target rare disease cells that exist in hard-to-reach tissues. Unfortunately, correlates of control are still unknown, making treatment interruptions the only interpretable outcome, unless, of course, the picture with reduction in levels of HIV-specific antibodies holds out, and that could be a more informative marker that would prioritize individuals for a treatment interruption. So the Bill and Melinda Gates Foundation put together a committee to try and come up with the guidelines for what an HIV cure should look like and how much should it cost. If we're to have a cure, obviously we want that cure to be effective on a global stage and in low and middle income countries that are already hard-pressed financially to contain the HIV epidemic. So the characteristics of that cure: efficacy, so absence of viremia in the absence of therapy for greater than 2 years. Early failure could be tolerated, but those late failures should be rare. The product should be administered for a limited period of time and not require tertiary care. The target population should be individuals who initiated antiretroviral therapy at any stage. And the cost and long-term safety should be comparable to antiretroviral therapy with negligible risk and less than $1,400. But if we look at the countries that are most disproportionately burdened with HIV infection, we see that $1,400 really isn't really going to be a very affordable enterprise. So here are some of the developed countries in the United States on the left with the highest per person expenditure for healthcare, followed by many European countries. But over here, if we look at the countries most affected by HIV/AIDS and what they spend on healthcare per individual per year, for example, we have Angola with less than $200 per individual per year, Lesotho with about $100 per individual per year. Then one gets the picture that a cure costing $1,400, even if that's achievable, is still going to be out of the reach of many countries already hard hit by the epidemic. So is a global cure realistic? The realities are that global antiretroviral therapy has still, in the face of global antiretroviral therapy, there's still millions vulnerable. It drives the rationale for a cure rather than treating the infection. However, advances in long-term formulations may offer a safer and scalable and more practical solution, particularly in low and middle-income countries. And safety is going to be a very important thing. I mean, antiretroviral therapy is an incredibly safe way to manage HIV infection. And if one is going to offer a cure strategy to someone who's infected and has the option of antiretroviral therapy, then that cure strategy is going to have to be as safe. And I think that's going to be a very tall order facing cure researchers. I'd like to finish by bringing to your attention the Miami meeting. It's held every 2 years. And the meeting is really focused on this stuff that I've been talking about, how HIV persists under therapy, and what are the strategies being explored to eliminate HIV infection. So it's a great meeting. Unfortunately, you run the risk of seeing some of the speakers wandering around with their Speedos. Not a pretty sight, but I hope some of you can make that meeting and enjoy the beautiful city of Miami in December. Thank you for your attention.
No questions? So I have a question.
Okay.
Just it's more your opinion. Do you believe using one of these strategies, is it possible to really cure HIV infection?
The question is, do I believe, in my opinion, that one of those strategies might lead to a cure? Well, we have Timothy Ray Brown, who's so far the only validated HIV cure out of the 38 million or so people infected with HIV. A cure is possible, but again, that was only in the setting of individuals who require a bone marrow transplant because of hematologic malignancy. So, theoretically, genetic therapies that use gene editing technology, like CRISPR-Cas, to eliminate CCR5, and repopulating the individual's bone marrow with edited hematopoietic stem cells, yes, theoretically that would give a maybe even a sterilizing cure. But is that type of approach only going to be available in rich countries that have, where the insurance is going to pay for the cost of the transplant, which is, significant? And then we have the issue of safety. I mean, I think it's going to be very hard for gene editing approaches to ever approach the safety of a long-term antiretroviral therapy. So I'm skeptical in terms of the practical applicability of that strategy. Michael.
The only cures we've had so far have been rendering cells HIV resistant, but there are some viruses that will escape that strategy, as we've learned. So I have two questions. The first is, do you think that there's another cellular target that could be knocked off or induced to render host cells completely resistant? And two, can you maybe talk a little bit about why some people in this room and elsewhere like the idea of neutralizing antibodies to help in cure strategies?
The first question from Professor Lederman is the genetic approach to eliminating CCR5 only works if an individual has a virus that has a tropism for CCR5. Some individuals, a small percentage of individuals, harbor CXCR4 viruses, so they use a different co-receptor to CCR5. And one individual who underwent a bone marrow transplant rebounded because that individual was infected with a CXCR4 virus. So in the same way we define patients who would be suitable for co-receptor inhibitors such as Maraviroc or Vicarivaroc, you have to phenotype the virus that those individuals are infected with. So there's a level of screening involved. So that approach would not be amenable to everybody, only to those who are infected exclusively with CXCR5 viruses. Are there other cell types that could support HIV persistence? Of course, I'm biased in that. There may be non-CD4 cells, myeloid cells, supporting HIV persistence. And we have a paper that we can press that I think makes a convincing case for that. But I think the genetic modulation will still work in the face of a myeloid reservoir, because it has been shown by Miriam Murad and others that those cells are continually being repopulated from early pluripotent stem cells. So the idea that you may be able to reconstitute bone marrow and still have that resident macrophage reservoir, I don't think that's going to be a big obstacle to this type of cure strategy. Second question is, why are some people fixated on the use of broadly neutralizing antibodies? Actually, I think it's a very attractive approach to the cure. Next week, you'll hear from Ron Desrosiers, who is using adeno-associated virus to deliver broadly neutralizing antibodies. This is all preclinical work, but at least we have appear to be one cure. It's called the Miami monkey, that was infected for 2 years, received a single intramuscular AAV injection, and with 2 AAV constructs containing 2 different broadly neutralizing antibodies, and that monkey was at least functionally cured. And there are other monkeys that look like they're going the same way. The obstacle to that is the anti-idiotype response, where the immune system makes antibodies against the antibody. But that's a scientific problem that is trying to be worked out in the lab just now. But with broadly neutralizing antibodies, of course, if it can be scalable and the cost kept down, it does offer, I think, a very attractive add-on, to, for example, immunotherapy, because it's unlikely that one single strategy is going to pay off. But again, we're talking about safety and cost, scalability. So, but those are things that other people are wrestling with. But in my opinion, I think there's a strong place for BNAbs in cure research.
Hi.
Barney.
My name is Beatriz, and I'm a pediatrician, so that is my bias. I was curious to hear what are your thoughts regarding these strategies you just presented on thinking about pediatric infection, mostly perinatally infected kids.
Yeah. An excellent question. Again, the Mississippi baby derailed some of the efforts for infants. In that case, it was a 4-year remission. It's unclear whether this reflects, in general, a characteristic of pediatric infections, because 4-year remission is not something that's been seen other than in Timothy Ray Brown. It's not been seen in adults. The longest remission has been the London patient, which I think is 3 years right now. But if you look at Catherine Luzuriaga's cohort, some of those individuals, some of those pediatric cases also look like they've seroreverted. But these are individuals who are still, for the most part, on antiretroviral therapy. And I think Catherine and her team have been reluctant to discontinue treatment because there's really no anti-HIV immunity. So even a single virus could fuel viral rebound in the absence of immunity. So they're treading very carefully with that cohort. Barney?
Yeah, most of the cure strategies seem to be focused on preventing or protecting the CD4 T cell and eliminating the reservoir in CD4 T cells. But you mentioned the virus could also be sequestered in lymph nodes. And just like in Ebola or Hunin virus, you can sometimes get infection of immunoprivileged sites like the brain or the eye or semen. And then, so how do you, fortunately our cured patients demonstrate that maybe those are not problems, but what if those other reservoirs may be problems?
You know, that's a tricky question, and one that I worry about as well, because, you know, there's a bizarre experiment that was done by a guy called Greg Burton where he took ex vivo HIV particles and injected them into mice, and you know, not skin mice, not humanized mice, and then 8 months later took the lymph nodes of those animals, chopped them up, and was able to grow the virus out. And if you look at the images from Tim Shacker, where you see, you know, virions deposited on follicular dendritic cells, they're trapped there. So they're not actually even intracellular, they're on the cell surface, but it's possible that some of those virus particles can be retained for extended intervals in an infectious form, if Greg Burton's experiment is right. So that's a massive depot of virus particles. And it's unclear how long those virus particles might retain infectivity. Unfortunately, you know, we just don't have enough follow-up data on the longevity of surface-associated viral particles. And then, you know, that could be problematic. But for that reason, focusing on taking out the reservoir. So even if that virus on those FDCs retains infectivity to extended periods, the only way they can do harm is if they're allowed to infect another cell. So having broadly neutralizing antibodies, you know, ever present to maintain vigilance and protect cells from any virus that might leak out of those deposits, I think is why we see the cure in, or at least long-term remission in those two individuals who went through the hematologic stem cell transplant.
Okay.
Okay.
Professor Stevenson. Professor Stevenson.
Thank you.
Thank you for your great lecture.
Obrigado.